So today is a special grand rounds celebrating the life and career of Henry Swan. And we're very fortunate to have our visiting professor, Dr. Joe Buyske, here with us. Let me, as I do every year, introduce you to Dr. Swan and just review some of his accomplishments and why he helped put us on the map here at the University of Colorado and this Department of Surgery. So Dr. Swan was born in Denver, and he went to Williams College and then Harvard Medical School, where he graduated at the top of his class and was also a junior AOA. He did a couple of years of residency at the Peter Bent Brigham Hospital as well as Children's Hospital, Boston Children's, and then World War II started. And like many other young men and women of that generation, he signed up and basically was assigned to the European theater, where he quickly rose to lead one of the surgical teams there in Europe. After World War II, he was recruited back to the University of Colorado and started his career as an assistant professor in 1946. And he quickly rose through the ranks, and by 1950, 4 years later, he was appointed as the first full-time chair of surgery at the University of Colorado. Prior to this, all the chairs had been part-time people with a private practice. He was the very first full-time chair. And he really put the University of Colorado Department of Surgery on the map. He was a pioneer in open-heart surgery, and he brought hypothermia into clinical practice. In the first part of his career, he used hypothermia and did very quick 6-minute operations and did some of the very first open-heart procedures in humans. And as this field developed, of course, the heart-lung machine came online, but hypothermia was still very important in practice. He was extremely charismatic. People came from all over the world to visit the University of Colorado and this hospital, and really it was a golden period for this department. Dr. Swan passed away about 22 years ago now, and his legacy lives on, and the faculty, his family, and friends put together this yearly event where we invite very distinguished people like Dr. Buyske. Now, Dr. Buyske is an extremely accomplished surgeon as well as administrator and educator. So she is an extremely important person because she's the executive director of the American Board of Surgery. So she and her team basically design the process of education and certification for all of us. In addition to that, she's still very clinically active and is an adjunct professor of surgery at the University of Pennsylvania, where she spent the major part of her career. She received her bachelor's degree from Cornell, and she majored in English, and then went on to Columbia to do her medical school training, and then did her residency at the Massachusetts General Hospital. She started her career at the Leahy Clinic and was there for a couple of years, and then moved to the University of Pennsylvania, where she quickly rose to leadership. She became chief of surgery at Penn Presbyterian Medical Center, which is one of the hospitals in that system. She belongs to many societies, held many leadership positions, and is past president of SAGES, Society of American Gastrointestinal and Endoscopic Surgery. She is also an active humanitarian and spends a couple of weeks every year in resource-poor countries and goes and volunteers in places such as Haiti and Nepal. She's published extensively. She's invited all over the world and really understands the issues in terms of credentialing and surgical education. She has a wonderful family with 4 children, very successful children, and in between all this, she somehow finds time to do marathons, and has completed over, I think, 20 marathons or so. And it's really quite impressive, Joe, what you have accomplished in the organization that you are now leading. So with that, I invite you up to the podium. This morning's presentation is to protect the public and enhance the profession, and this is through educational programs. Joe, thank you so much for coming and visiting us. Thank you.
That was an incredibly nice introduction. I think the two things that he called out that I'm proudest of are having been an English major in college and being clinically active. I would say that although most days I go to work in a suit, and I will say when I was a resident, we used to call surgeons in a suit the most useless thing on earth. But the days that I go to work and wear scrubs are the days that I feel my most authentic self, and I say that with all sincerity. So today, though, I'm here to highlight that other half of my work, the surgeon in a suit version, because I think for most of us that part, the legislative part, the administrative part, it's sort of like your utilities. It's like the electricity service and the gas service. Those things hum around in the background, and they only come to your attention when they're a little bit annoying or when they're a little bit scary. And as I've immersed myself in that world, I've learned how interesting, valuable, important, and how quickly things can go wrong if you don't do it right. So if I have my way with this talk, some point along the way, some of you in the room are going to think, I want to get more involved in that. And it turns out that you can get involved in that at really every stage of your career, even from medical school, although that might be a bit of a stretch, but certainly from residency, from being a young attending faculty, community doctor, throughout your career and even into your early retirement. There are sort of opportunities to have an impact on these things that impact us. And I think that we're in an interesting cultural moment where people are waking up to the idea that they have to use their voice, that they can't sort of sit back and let things happen to them, whether that's in the political arena, the professional arena, or other arenas. And so people who never ran for office are running for office. People who never voted are voting. And people who never had a say in their profession, whether that's healthcare writ large or in their own hospital or residency politics, are starting to want to have a role. So I hope that this will be a little bit of a window into what roles you can have and how some of the things that affect you work. I'm still in the habit of giving disclosure slides. I'm not sure if I needed to, but I am paid by the American Board of Surgery, so everything that sounds like it's in the interest of the board may perhaps be. And I'm also a volunteer director of the American Board of Medical Specialties, which has a lot of impact on your choices as well, even though you've probably never heard of it. They also asked me to submit a list of objectives that you probably have at hand and are summarized by what I just said. Of course, I read about Dr. Swan before coming and had heard of him before I arrived. And of all the quotes that I came across, I think I like this one the most, especially pertaining to today. And that's because I liked what he had to say about the hazards of making change, really, that he knew that it was significant, that he knew that it was sort of scary. And I like the fact that he dealt with cold things, because I'm hoping that when we come through all these changes that everybody will be sort of warmed up again and ready to go forward. So this is the image of the board, sort of like the IRS. We're from the board and we're here to help or not. So I'd like to talk a little bit about all of the national and international environment that we all work in. It's helpful to understand the lever arms that are at work here. So we're often confused with the college. Even as early as last week, people were either blaming the college for decisions of the board or writing letters to the college about the board. They call the board when their college memberships expire. And we're two different organizations. There are really three pillars to surgical life right now. One is the education and advocacy limb, which is the college, and all of our specialty societies. Their main role is continuous education and advocacy for surgeons and for surgical patients. So the college is a member society. You have to apply to get in. You have to pay dues. They have a fantastic meeting every year. If you haven't ever been there, the House of Surgery together in one place learning is an amazing event. They also have an office in Washington where they defend your rights. They defend you in terms of reimbursement, payment, billing standards, how your cases are calculated, and other things that impact directly upon you and your ability to get your work done. I made that sound all about money, but it's really about your ability to get the quality of work done that you need to do. So that's the college. That's the American College of Surgery. That's different than the American Board of Surgery. Then there's the world of boards. So most of you probably took your boards quite quickly after medical school, during your internship, depending on your state. And state boards across all specialties. They don't deal just in surgery. They're responsible for the entire world of medicine at a very early stage. So they certify that you have completed the necessary details to be able to be a doctor in the United States. A surprising number of people, 1 out of 5 doctors in the United States, gets their state boards and does no further training. So they are general doctors. You live in Denver, so you probably don't know very many of them. But 1 out of 5 doctors in this country doesn't do a residency. They do an internship and practice as general practitioners after passing their state medical boards. So they're a different group. They don't deal exclusively in surgery. They deal across the spectrum of medicine. And then the last that impacts all of us here in these teaching hospitals is Residency Review Committee, and they're responsible for training programs. They make sure that your program has the tools it needs to make sure that you become a good surgeon. And we walk arm in arm with them. They're not interested in you as individuals. They don't keep, well, at least they say they don't keep individual records. They only keep program-level records. And we're linked because in order to be certified by a board, you have to have trained in a ACGME-accredited program. And in order for a program to be ACGME-accredited, the vast majority of their residents have to pass their boards. So we move together in lockstep, tightly linked, in the interest of medical education. So it's 3 limbs, and I think of it as a 3-legged stool. You can't take any of those limbs out without the whole thing falling down. There's the accreditation, the institution that you work in, and I would say that once you leave training, that becomes the purview of the Joint Commission. So they make sure that the institutions are prepared to take care of patients and support your practice and training in the way that you need. There's the education limb so that you're able to continuously learn, linked to advocacy. And then there's the certification limb that addresses you as an individual, that assures your institution that you as an individual can fulfill their needs and the needs of your patients. So they all hang together as a 3-legged stool. The ABS itself, approaching 100 years old. The mission statement of the ABS includes the statement that we are here to protect the public and improve the profession. I think that's little known. The ABS isn't actually about surgeons. It's actually about the public, and we'll go into that a little bit more later. We do this by setting standards of training and assessment and by certifying the individuals who meet those standards. And that's our testimony to the public. That's how we protect their trust. And in my training, it was very clearly considered an honor and a privilege to become board certified. It wasn't quite as clear then. It hadn't actually evolved then to be almost mandatory. It was the brass ring that you grabbed at the end of their training to prove that you had all that it took. So if you're interested in surgical leadership and being someone who sets the trajectory of the field, there is a path towards working at the board. This is what the board looks like. It's 38 volunteer directors. We have about 400 volunteers who work with us in addition. And the directors, I just want to emphasize this, they are elected from societies as leaders in their societies. It's quite a competitive process. And then when they win, they get to give us 30 volunteer days a year for 6 years. So 6 months out of the office, away from their homes, developing examinations, developing assessment processes, working with other countries, the other 3 legs of the stool to move the profession of surgery forward. So it's quite an extraordinary volunteer effort, and it's almost unique to surgeons. I've never met a group of people who work as hard and are as willing to donate their time in so many arenas, and this particular one I think is an undersung one in the world of surgery. We have 30,000 people who bear the American Board of Surgery certificate. Most of them are certified in general surgery, and very many of them are certified in an additional field. And most of them are meeting ongoing certification requirements. When we work, we have sort of 2 interests from the board. One is initial certification. That has to do with resident training standards. And in that area, we work with program directors, we work with the college, we work with the other leadership societies in the RRC. And then once you finish with training, once you've gotten that sort of diploma of training, your initial certification, we work with ongoing certification for the rest of your life, the rest of your practice life. And for that, we work with specialty societies, with regional societies, and with education societies. So I arrived at the board in 2009 after having had about 20 years of clinical practice. Since part of my purpose is to help you figure out if you're interested in this kind of work, my own career was partly intentional and partly opportunistic. A lot of people manage their careers by walking through sort of every door without really having had a plan. I had a partial plan, which was that somewhere in my 30s, Well, take a step back. When I got into medical school, my father was a PhD in biochemistry and pharmacology. He was very unimpressed with the idea that I was going to medical school. He said, doctors save people one at a time. Scientists save entire generations. So, thank you, Dad. So, but I did bear that. I did bear that in the back of my mind. And I thought, and I loved surgery. I loved taking care of patients. I still get letters from my patients to this day, even though I haven't had a full-time practice for 10 years. I wanted to have a full career where I mastered what I was doing, was the go-to surgeon, did big cases, took care of people, and then I wanted to take a step where I had a larger impact, a broader impact, a national level impact on healthcare. I didn't know what that meant, and no one around me really knew what I meant. When I told people about it, they were like, do you want to work for the WHO? It's like, yes. What exactly is the WHO? Do you want to be the Surgeon General? Maybe. How do you get to that job? So it was that sort of specificity. And then ultimately I wanted to end up in an under-resourced country and work in one of those environments for 5 or 6 years before I hung up my scalpel. So I arrived at the American Board of Surgery when they were really very ready for change. There had been a mandate to change surgical training. And after a lot of head scratching, some strategies started to evolve. So the history was that I actually barely knew who the board was for most of my training, and maybe you don't either. The in-training exam exists, was sort of loosely linked to the board in my mind. I understood that there were some tests. And really, we only encountered residents at the very end of their training where they had to send us a letter saying that they had 750 cases and the program director signed off, and that was about it, which is sort of an interesting problem because if you meet people at the very end of their training and their training isn't ideal, it's a little late to go backwards. So the curriculum at the time was whatever came in through the door. The plan was follow me around and maybe you'll learn something. And we decided that we needed to change things to have a better standard so that we knew exactly what was coming out of the training programs. And we decided that we had 3 places where we could affect change. One of them is at the entrance level into residency, so what you got when you came out of medical school. We could change the process of residency itself, and we could change the standards to get out of residency at the very end. So starting with the first lever arm, which is entering interns, people as they come out of residency. I'll touch on this really just briefly because as it turns out, no matter what the board thinks, you can't really change the AAMC or what the deans plan on. But we did have some suggestions, which is that medical students were showing up at residency at wildly varying degrees of capability. Some of them could suture, some of them couldn't, some of them knew what to do with the patient in respiratory distress, some of them had no idea. And all of them were sort of handed a beeper and expected to start working on day one. So working with the societies that we've talked about, the American College of Surgeons, the program directors, and the Association of Surgical Educators, a boot camp was developed to set a list of tools that we expect interns to be able to know before they start residency. A lot of programs have their own. You, I think, have your own. But they all sort of started off out of the same primordial swamp of figuring out what the list of skill sets that would make a competent intern early in their training so that they weren't afraid, so that patients weren't at risk, and so that they could take advantage of their training rather than trying to catch up at the day of entry. This is the initial list of critical content. It crosses across different skill sets. Some things like cognitive skill sets like handoff, technical skill sets, including things like putting in a Foley catheter, interpreting basic radiographs. So the boot camps have been gathering momentum. They're not a requirement yet, but they're becoming ever more of a standard, and I think that they've been a tremendous improvement over relatively recent history in both patient safety and in the residents' ability to take advantage of their training. It wasn't that long ago before there wasn't a structure to surgical training. It wasn't really clear what the box that included was. Does it include, should you be able to do a parotid at the end of training? What about a burr hole? Should you be able to set a fracture? Different programs had different standards. Different tests had different standards. There wasn't really a definition about what was included. So the board, after a convening meeting of multiple different societies, set itself the task of developing a curriculum, and that is now the much taken for granted SCORE. So this is a 10-year iterative process. We examined both the reality of resident experience and the expectations of practicing surgeons, and it was an unprecedented effort. We started actually by asking surgeons across the country, particularly program directors, which of the list of 960 cases that were being done by residents they should be capable of doing independently at the end, and the list that came back was about 650 of them. So we went back again and said, well, that's okay, except for the average number of Whipples done by a resident is 1, plus or minus 20. And so we can't expect that all of them are going to be independent, which are the ones they really need to be independent on. And then we focused our training efforts on figuring out how they could be independent on those and what the skill set was required in order for them to be safe in developing their skills in the other area. So that was SCORE. It was a 10-year, $10 million process that put the brackets around surgical education so that we could start comparing apples to apples and oranges. This is what you're all expected to learn. This is what you're all expected to know as you enter the programs so that you can learn it. And then, of course, there's no curriculum without an assessment, so we started switching all the board processes to match that curriculum. All of the exams are based off of the SCORE curriculum. All the assignments to the people who write the exams are based off of the SCORE curriculum, and we have a definition of how deeply you're expected to know each of the different categories. So when we put together an exam, we actually have the SCORE outline. We have experts who look at the list of categories and say, about a tenth of the exam should be in the alimentary track because that's the experience of the residents. Then we send out assignments to people and say, we need you to write 2 questions on the stomach, one of which should be on a stomach cancer, one of which should be on benign disorders. And that's how those exams are constructed. We take a look at the practice patterns of physicians in the field, practice patterns and training patterns of residents, and reflect off of those. So there's an actual science to exam development that's kind of fun and kind of interesting. In the apples to apples and oranges to oranges category, we started adding requirements into training, something above and beyond. I've done 750 cases, and my program director says I'm ready to go out into the world, because we wanted to be sure that the standards were the same across the country. So we started requiring advanced cardiac life support, advanced trauma life support, and the fundamentals of laparoscopic surgery. That just started in 2010, so we could know at the end of training that everybody was equally competent on all these things. And we relied on the societies. We didn't build those products. We relied on valid tools that have been developed by our peer societies. Surprisingly, there was no requirement that anyone ever watch you operate and say that you were doing a good job. So we instituted a requirement for operative assessments. It's a very soft requirement. It's sort of introduction of concept that someone should formally sit with you, give you feedback. And believe it or not, the first requirement was only 2 cases in your entire residency. And it was a little bit of a hill to overcome. So we added 2 operative assessments, 2 clinical assessments, and they're increased up to the current list of 6 and have been sort of embedded in requirements for surgical training. And most programs far exceed that. But we're setting a bar for the lowest acceptable standard. So you are at an elite program where all these things were coming into play anyway, but we're responsible for programs across the entire country. So that's the bar. Somebody has to look at you and watch you do at least 6 operations and interact with at least 6 patients and give you feedback before you can come meet the board. More recently, we felt that there was a better opportunity to learn later in training if you had more exposure to the operating room earlier on. As well as better satisfaction of the trainees, most of whom went into surgery because they like to be in the operating room. After we had looked at studies of surgical attrition and realized people tend to drop out in their second year, maybe in their third year, we thought they might feel more satisfied with their field if they were in the operating room as they wish to be, and also be better prepared to start learning the responsibility of surgery in their third, fourth, and fifth years if they had more operating time. And again, the surprising number of people finished their second year with cases in the double digits. As few as 30, maybe as many as 90. It's not a lot if you spend 2 years of your life trying to be a surgeon to not spend that much time in the operating room. So we just recently instituted a requirement for 250 cases, a requirement for residents to teach other residents in minimum numbers, and an increase in the overall case number to 850, which seems pretty reasonable given 5 years of training. Then we started getting a little bit more sophisticated, a little bit more complex in the requirement. The fundamentals of endoscopy curriculum, which is just coming to fruition this year. And if you're a 5th-year resident, we're not kidding. You really have to have finished it. Please do so and make sure it's ready for your application. And that defines a program of study that allows you to testify to the competency of a particular skill. That is the only place where we have a national standard for that. A set of study parameters followed by, with a curriculum, followed by an assessment in which we're able to testify that you actually can do upper and lower GI endoscopy. We don't have that for a single other procedure on a national level. So that's sort of our toe in the water and is really pretty exciting and ushers in the era of entrustable professional activities for residents training, which we're about to pilot and I'll get to in just a minute. So as we look at The small changes that we've made in residency sort of pile up over time. Look back 10 years, 750 cases and a program director's assessment. Now we have case requirements, we have learning requirements, we have exposure to operating room requirements, feedback requirements, standardized tool. It's quite a different world. We can say something different about residents, and you can know when you meet a resident from New Hampshire, you're from Denver, or someone from Florida, that you've all had a very similar process, and that if you're going to work together, that you have a certain shared baseline knowledge. So as we continue looking at resident training, these are sort of the core values that we focus on when we're refining surgical training. People ask me a lot about, are we going to shorten it? Are we going to turn it to core training, 4+1 training? And that's come up over and over again in the last 15 years ago since the Blue Ribbon Committee. So I would say at this moment we don't have a clear path to that, and yet these standardizations do allow the door to open for that, because if everybody's doing the same thing in their first 3 years of training, it becomes possible then to move to another institution or to focus your training if you understand what happened in those first 3 years. If you never understand what happened in those first 3 years, it's not the same from institution to institution, then it's not possible to make a core section of training. So we're laying the groundwork to be realistic about taking next steps on that. One of the ways we lay the groundwork is by working with different countries and by learning from them. I was a visiting professor in Chile not that long ago. They have a 3-year core surgery training process, after which you're able to do basic surgery, hernias and gallbladders, and also to serve as a first assistant to people who did additional training, which is usually 2 years of additional training that then allows you to be a GI surgeon or a more advanced surgeon and do the things that we think of as more complex cases. The Royal College of Surgeons, training in Europe, training in Haiti, all have added information to our pool as we start trying to think about ways to change things. Turns out good surgeons are trained in every country in the world, and they're done by a variety of different pathways, which allows us to kind of start shaking the centrally held tenets of our training process and figure out what might be different. So we've worked for several years now with the Royal College of Surgeons in Singapore, and Singapore's government function is such that the Ministry of Health can make a decision and it must be implemented by every hospital in the country, which is just awesome. Works really well if you're trying to make change. And so they decided they want to switch from the British system, the Royal College system, to the American system. And one important lesson there is that no matter what you think of our system, you might feel that it's flawed or complicated. Other countries still consider it perhaps the best system in the world and seek to emulate it. So we've been working to change their assessment to our model, and in doing so, I've developed much deeper understanding of what the Royal College system improves. And probably my single favorite detail of that is that their high-stakes assessment, their equivalent of the written exam or the qualifying exam, happens in training. And you can't get out of training until you've passed it. The neurosurgeons actually in this country do that also. You have to pass that. And that makes a lot of intuitive sense, makes us look at our own processes. Because why would you take your trainee, finish them, send them out in the world where they don't have access to their teachers anymore, and then maybe they fail that exam? Then what? What are they supposed to turn to? So in their system, they stay at home in their training environment until they've passed that exam. And we took advantage of that and actually started introducing the qualifying exam in the first year as a little bit of a test to see if people could pass it, to see if people would embrace that idea. We like to sort of open doors with little trial balloons. So that's what we learned from working in Singapore. In Haiti, I've been involved. I sadly turned into a surgeon in a suit in Haiti as well. I used to go and operate there, and now when I go, I don't even bring scrubs because I've been involved in the Ministry of Health there, developing a training system different than their previous training system, which was basically work in a public hospital for 4 years and then become a surgeon. And now it's a structured system with a curriculum matching their local needs and environment, but very much paralleled on ours. They have limited resources, and so what they wanted out of the 5th year of training was to send their chief residents abroad to go see transplant programs, to go see cardiac programs, to learn what was possible. And although there's a lot to be said for learning what's possible, we had the advantage of being able to say, you are in a field where your 5th year residents can work in a supervised, safe, mentored environment as they transition to practice, as they get ready to go out to places where there are no other trained surgeons, where they're going to be by themselves. So you can do what's been so very difficult for us to accomplish in the United States, which was a resident service, a place where the residents can see their own patients, operate, and have their teachers beside us. So that's working to develop a program from scratch. Let us look at our own processes a little bit and see what it was that we needed to work with. We have a lot of surgeons visit us from other countries. We have a lot of wonderful resources in Philadelphia, fantastic museums, great dining, the Liberty Bell, but they all want to go see the Rocky statue. So, and they always send me their pictures after they've gone there because we don't take them there; they find it on their own. So these are our Dutch surgeons, and I put the yo word there because that is very Philadelphian. Also, in my quest to develop gender-inclusive language across the board, yo works really well, and so does y'all. You don't have to say he, she, they, or it if you use yo and y'all frequently in speech. So I give you that small gift. In terms of entrustable professional activities, professional activities are the next project of the board, and a lot of education-focused training programs are already working on adopting them, as are a few of the specialty fields. So it passes the sniff test that we haven't really been able to address, which is that someone should be able to look at a resident and say, you can handle the patient who came in with abdominal pain. We haven't had a process to embrace that, but EPAs do that. The unit of professional practice that a trainee can be trusted with as soon as she or she has demonstrated, or y'all have demonstrated the necessary competence to execute that activity. So we have a lot of de facto EPAs. It was a little bit of a push to get people to believe in this process, but we trust residents to do things all the time without supervision. Much of it as a matter of convenience, much of it because it just plain makes sense. So positioning patients in the operating room, perhaps draining abscesses in the emergency room, wound management, central lines, after a series of learning steps and sign-off. And then the fundamentals of endoscopy curriculum is essentially an EPA, a set of learning standards that you have to meet. And then in the end, you are able to do these things independently. So we have them embedded in our field already because we just can't be everywhere all the time, and you have to trust somebody to do something. But we decided to put more structure around it, learning from our colleagues in the Netherlands, which is where they started from and have been implemented in a practical manner in some programs, primarily orthopedic surgery, in Canada. We have in the United States milestones that we use to assess residents, or actually the ACGME uses to assess programs. And the surgery milestones are a little hazy on the sort of technical skills front. The pediatric surgery milestones are very much geared towards you can do this operation, you can take care of this disease set once you've met the milestones. So we're sort of shifting to that in general surgery. And so a pediatric surgery milestone might start off with this trainee knows the anatomy of a TE fistula, 2 can describe the steps of the repair, 3 can do a simple repair, and 4 is independent in the repair of the TE fistula with sort of instructions and guidelines to go along with that. So we've developed 5 EPAs over the last 2 years with the help of our collaborators. And the idea is that in surgery there are probably about 20 EPAs that incorporate the whole field. It's not operation-specific, it's sort of realm-specific. And these are our initial 5. We don't think that this embraces the whole field, but this is where we're getting started. Manage a patient with an inguinal hernia from start to finish. Manage a patient who presents with right lower quadrant pain. That would carry you through knowing how to do an appendectomy, but all the variations in the workup and complications that come with that. Manage a patient with gallstone disease. Provide consultation, and that goes back to somebody should observe you talking to a patient and communicating. And evaluate and manage a patient with blunt trauma. So these are the first 5. We have 28 pilot programs that eagerly volunteered to take them on. Each of them will do 2 EPAs. We have a 2-year study. One thing that we know for sure is that we're going to make mistakes. That's the lesson that was handed down to us from the Dutch, and actually in the United States, the pediatricians themselves are using EPAs. That was their advice to us. And the interesting thing about trying to make changes in surgical education is it takes a really long time to figure out if they're working or not, because it takes 5 years for everyone to be trained, 10 years before you can start to see any practice differences or outcome differences. But we're starting that process now. EPAs are starting this summer, and we will follow them with interest. But to me, this whole package is a really promising set of changes. Getting back to the idea about core training versus continuing with general training, I talked about the structure in Chile. So not that long ago, all residents in a given program had to do the same number of rotations, the same types of rotations. Everything had to match according to the RC, and that was to prevent any kind of favoritism in a residency or any unconscious trends towards giving preferred rotations or more difficult rotations to some residents and different rotations to other residents. And so we broke down that rule into its essentials, which is the broad structure of resident training, but we allowed people to start doing specialty rotations in the last 3 years of training for up to 12 months so that they could start to track into the fields that they were interested in. We followed up with a generalized study about that showed that programs were really able to take advantage of it. I'm the person that every single application for that variation comes through at the board. And the first year, people talked about canning it because only 2 programs applied. So nobody's interested. It's too complicated. We can't do it. The next year was 12 programs. Now we have about 40 programs out of the 260 that take advantage of flexibility and training every year so that a resident who wants to go into breast surgery can trade rotations with a resident who wants to go into cardiac surgery in their 5th year to get more oncology or more plastic surgery. And the cardiac trainee can get more vascular surgery or more thoracic training. So you can track a little bit into your field of specialty to allow you to be better prepared when you start your fellowship. Or if you want to go directly into practice, you can get a broader base of general surgery practice. You could do more endoscopy. So it's a little bit like early specialization pathways for every single field. The most exciting advantage I've seen taken of that has been in the non-ACGME accredited fellowship of transplant surgery. So it doesn't have the same rules imposed on it as fellowships like pediatric surgery. And at WashU, they took a resident in the program. They've done it twice now. Used the flexibility and training pathway to give them additional transplant rotations as well as additional vascular surgery rotations and a few other pertinent rotations so that in their last 3 years of training, they did 12 months of transplant. So they then stayed at WashU to do their transplant fellowship, but they gave them credit for a year. So they shortened their training by 1 year in their own program, under their own watchful eye, with an excellent resident and a committed faculty. But it still is kind of proof of principle that if you allow people to track in a controlled circumstances and good programs, that we might be able to edge our way towards core training and then specialty training, or at least individualized training to people's interest. I mentioned about moving the qualifying examination into the 4th year. The first year that we did that, which was 2016, only 13 people took it. We did it with no warning. Everybody had to have met all the requirements to take it by their 4th year as opposed to by their 5th year, and not very many people were prepared to do that because you have to push your cases forward and meet all the other requirements. 12 people took it, or 13 people took it. 12 of them passed, which is quite a bit higher than the regular pass rate. And we had a similar number. I think it was 25 people took it last year, and almost all of them passed as well. So it turns out that you can accrue the surgical knowledge that we expect you to get over 4 years of training, which may then free you up in your 5th year to spend more time using opportunities to manage complications, to focus on judgment, or to focus on a different career pathway if that's what you're interested in. So these are all the building blocks that have gone into redesigning residency. So it looks like it's slow, looks like it's sort of opaque, but in fact it's a forward-thinking process of moving the blocks into place. SCORE, defining the curriculum, working backwards from that, defining the skills of the people who need to start training. Increasing the residency requirements so we have apples and apples and oranges, and people might be able to move from training program across sources. Adding flexibility so you can start to trend towards the training, towards the field that you want to go into, and adding milestones and EPA so that you really are competent when you get out. So this is what the House of Surgery looked like at the very beginning. Then we added initially FLS, ATLS, and ACLS, added 2 to 4 clinical assessments building on that, allowed flexibility in training at the end of training, inserted the qualifying exam after the 4th year, and starting to look a little bit like core training plus advanced planning. Improving the quality by adding 250 cases, starting with EPAs by adding FES, and then you start to work on areas of particular interest or focused expertise, either in the form of flexibility and training or an early specialization, or by fellowship training afterwards. So a few representative fellowships. There are general surgery fellowships, transition to practice or otherwise, global health fellowships, vascular surgery, fellowships across the map, some of which are directly related to general surgery and require it, and some of them are slightly different. And then after general surgery residency, there's the fellowship house, and there's the practice house, and you can continue to specialize. Actually, even at dinner last night, we talked to people who had shifted their practices, used to do trauma, now are doing surgical oncology, I started my career doing pancreatic surgery at the Leahy Clinic, switched into 20 years of minimally invasive surgery. Now I do acute care surgery. So the continuous lifelong learning that allows you to change your focus, to focus your field of interest, to get good at it. And then if you've done it for a long time and want to change it to something else, ways of doing that. Some of you are very interested in continuous certification and maintenance of certification. I have a whole talk about that at dinner tonight, so I'm only going to mention it briefly, but I am around and available if people have specific questions or things they want to talk about. This is because this has been a very hot topic recently at the national level around what it is that we're doing with maintenance of certification and continuous certification. Should say, why do we need this? We have the societies. We have the opportunity to learn what we want to learn. We have the Hospital Credentials Committee. They'll stop us from doing things that we shouldn't be able to do. We have internal reviews, and we have education opportunities. So this is the official list for why we have such a thing as lifelong certification or continuing requirements. And to me, it doesn't really get at the heart of the matter. The heart of the matter is actually about people who aren't in medicine. It's about patients. It's about other stakeholders who need to understand what it is that we're doing. It's kind of like a vaccination program. So it protects the whole herd. So in the 90s, we had a big malpractice crisis where everybody was getting sued all the time, and physician advocacy groups were demanding tort reform so that we couldn't get sued for every single thing that went wrong. And the pushback from politicians, lawyers, and the public was that the profession wasn't regulating itself and that this was a good way of regulating. The people getting sued for things that they did wrong was a way of regulating the profession. So an externally imposed form of regulation that I have to say I think was pretty toxic. So continuous certification is a way of pushing back and saying, no, we do regulate. We have a tool that you can use, not the only tool, but a way of knowing that people have met professional standards, that they haven't had their license revoked in another city, that they haven't had a hospital action against them, and that they've continued to stay up in basic knowledges and continue to look at their practice. So it helps us as a herd testify to professional regulation and push back against the idea that lawyers and politicians should be regulating our field. It also helps patients. So all of you, if you have a cousin or a sister who needs to have surgery in another state where you don't really know anybody, well, you'll call someone that you do know. You'll call your friend the surgeon in that state, who will call their friend the obstetrician in that state, and then tell you what you need to know about those doctors. That's because you're in healthcare. And even that gets a little bit hazy by the time it's whispered down the lane. There really is no way for you to know who a decent doctor is in another area. My nephew needed an appendectomy in Kentucky. My sister called me in a panic, said, how do I know that this surgeon could do it? And it wasn't enough for me to be able to say, well, anyone who's ever trained in this country can do an appendectomy. But I said, check and see if they're board certified, because that is a basic bar that is reassuring to the public and allows them to know that people have met a basic standard. So my nephew is, 6'5" and 140 pounds and 20 years old and healthy. So that was a gift to that surgeon. Consumer Reports, last month when I was looking about how to pick a new car, had an article on healthcare, and they still cite board certification as one of the standard things that you should look at if you're trying to find a doctor. And again, they're not saying it's the best thing ever or that it's perfect. They're saying this is a basic bar where you can know that they know things, that they strive to keep up, and that they're professional. And people need that. So it's a service to the public. I don't know that I can even say I think it helps an individual surgeon. I don't think it does help an individual surgeon. I think it helps a field overall, and I think it helps our public face, and I think it helps people who need to try to find health care. So when we talk about continuous certification, that's the background. It doesn't that for you as a frustrated surgeon trying to meet standards, it's annoying, but it provides a greater good. It's sort of the herd effect. And we do know that over time, people's knowledge change. We had an old exam that had about a 95% pass rate for everyone who took it, and yet it changed. The pass rate was significantly different over time. If you were 10 years out, the fail rate was only about 2%. If you were 20 years out, it was higher. And by the time you get to be 30 years out, it was significantly higher. We actually do have some people who've certified for the fourth time, 40 years out, and they only pass it at about a 70% pass rate. So whether you like the test or don't like the test, what you can say for sure is that people's knowledge is different over time passes, somewhat perhaps for good reasons, perhaps for bad reasons, but it is different. So we need different standards as time passes for how to fairly assess people. So why did we make a change in how we do continuous certification? One is that people who were doing it didn't like it. They thought that the general exam that didn't apply to their practices didn't help them. They didn't like to take the time. How did we start to make the change? Oh, and they didn't like going to the test centers where they had to get fingerprinted and take time away from work and perhaps fly somewhere, perhaps stay in a hotel. I would say, rolling back, that initially the test centers were great because you had to actually, before you could go to those, you had to drive to a ballroom and fill in bubble sheets in one of 5 different places in the country. So the test centers were an improvement over that. Now they're out of date. Now we want to be able to provide it in a more convenient, less onerous manner. The board takes these things very seriously. We had retreats on it going back for the last 5 years. We realized that it needed to change. The ship turns very slowly. The changes take a long time to assess, so we tried to be really moderate about it. We sent out a survey in the fall of 2016 to try to get at the basic issues. About 5,000 people answered that, and the answer was, as expected, they wanted it to be flexible, to pertain to their practice. The people who do vascular surgery primarily didn't want it. Well, vascular surgery is not a good example because it's a additional training field now, but the people who did endocrine surgery didn't want to be tested on the esophagus, and understandably so. They didn't want to have to go to a test center on one specific day and have every part of their career hinge on a 5-hour exam. So we sent out a second survey. This time we got 10,000 responses, trying to hone into that a little bit more, and came up with a new model, which I think much better matches what we understand about adult learning, both how people learn and how they retain information. We're interested in the retention part. So we took a look at all of the case lists of people who'd recertified, picked the top 4 categories of cases in terms of volume, and constructed 4 different versions of the same exam to give so that people can pick something that's more related to their practice. We also came up with a core list of problems that go across surgery that we felt everyone should know. This year it'll be things like management of opioids, now that we've learned a little bit more related to the opioid epidemic, enhanced recovery, patient safety, geriatrics and frailty, some of the things that cut across all areas of surgery. So, rolling back to where I initially started, surgical education research as an opportunity for impacting the field, helping us all understand the best ways to make forward progress. It's funny, this was an arena that was completely unsexy for decades. Richard Resnick, who's one of the shining lights, said that he felt like a mole operating in the basement for years and years and years, and now he's kind of come up and everybody's shining bright lights in his eyes, and he's got the most experience and some of the most knowledge about how to improve, to shorten, to focus, intensify, and improve the quality of our training. So surgical education research, and with that, the impact that it has on all of our patients, both in this country and around the world. So global surgery as an academic field of focus. We need people in both of those fields to help improve this process that I'm talking about that affects all of us in so many different arenas. So where are we going with surgical education? I think that we are slowly headed towards core plus training. I think that we may well move high-stakes exams or assessments into training so that people don't, the rare person who really starts a residency program and isn't cut out to be a surgeon figures that out sooner rather than later, or the person who needs help in different facets at different points along the way figures that out before the end of their 5th year when it's hard to get some help. I think we'll move towards 5th-year credit towards fellowships. I think we're going to be able to enhance independence during training using EPAs, and that we're also going to find a way towards increasing skills evaluation and training, because we have so many societies and so many groups who are working on developing products that can do that are really high quality. So where is it that you can have impact in this whole sort of overarching group of things that tells you what to do? Certainly there's a lot of space in the roots that I know the best within the House of Surgery, committees in all of the different societies, committees right here at your hospital, working in surgical education as a field of research or professional colleagues, or volunteering for being one of the 400-plus volunteers of the American Board of Surgery. Then there's taking it up a notch, so people in the room who have worked in institution-wide education here, been in the dean's office, if you step up outside of surgery and start looking at medicine, pediatrics, radiology, pathology, and viewing it as part of a whole healthcare system, that adds a whole other layer of interest, complexity, and importance to the whole problem. So where can you do that? You can join your state medical society and work within that structure. You can join the AMA, which doesn't require a pathway through any of those other groups. You might like or not like the politics of either of those groups, but if you're silent and standing back, they won't change, and you won't be able to have an impact. And then outside the House of Medicine, You can pay attention to some of the legislation that affects you. Very likely your hospital's got some sort of newsletter that tells you what's going on here in Colorado or even nationwide. You can write your congressman, you can call them, and you can even run for office. So it's a time of activism. You don't have to just sit still and have things happen to you and then be irritated, frustrated, or angry about them. You can seek to understand them. You can definitely participate in the process. I'll emphasize the ABS because that's the route that I know the best. I started as a consultant in 1999 to the qualifying examination, back when we had little balloon bubbles written in for all of our exams. None of them were online or electronic. I became an associate examiner, helped to give the oral examinations because someone just sort of tapped me out of a crowd. There was a lot of that for a long time. You had to know someone who knew someone who knew someone, but we're trying to sort of disseminate opportunities. In fact, we just sent out a broad invitation for people who are interested in being associate examiners to get away from the internal selection. If you have a month, a year, for 6 years to give us, you could be a director of the board, and then there are a few other opportunities to work with us as well. So this is what I've sort of learned over time working in this field, that you have to figure out what you want 10 years down the line and start edging your way towards it, that you have to start turning the ship well in advance and start putting building blocks in place to try to change things. You have to be patient, that working across surgery it requires working across multiple arenas of thinking and specialty care. That surgical education, research, and leadership are, at the moment, underserved and very much value smart people with intention, and that the environment that we live in is not just about surgery and not just about our hospital, but that we're impacted by all kinds of larger issues outside. So I hope that some of you are interested in working in this field now, and that's what I had to say. Thank you.
That was a great talk. We have time for some comments and questions. Should I start with the first one? Rob, go ahead.
I'm wondering how much what has happened in the other boards in the ABMS has affected how the ABS works, and the examples being internal medicine, anesthesiology, et cetera.
So we do work really tightly knit together, and it's interesting because surgery certainly has a long history of people who are very independent thinkers, tend to like to be captains of the ship, to drive their own, to control their own lives and their own practices. Turns out that every field has got that personality, and the board structure is a loose federation that makes it hard to get everybody to march in step. So yes, some of the actions of the other boards have made us have to be a little reactive or a little bit more attentive than we might otherwise have had to be. On the other hand, we have the opportunity to learn from things. You mentioned the anesthesia. I think you're probably talking about their texted out questions that come out, I think 2 questions a week over the course of a year, so that for those of you who don't know, instead of taking a recertification exam of any type, if you're an anesthesiologist, you get 2 questions a week. I think you have 5 minutes to answer them. You have to testify that you're the person answering them, and that's their assessment. We actually put out the question of whether people wanted to get a question every week, and most surgeons said, please no. But they did want them sort of bunched and more convenient. It was something between 250 questions once every 10 years and 2 questions a week, which is how we landed on the 2 years. So we learn from them. We are affected by the things that they do. The American Board of Internal Medicine is the sort of classic where their whole series of exams was perceived as being very expensive and perhaps not even intended to be for the benefit of the doctors. I'm not going to speak to that. My belief is that the American Board of Internal Medicine was fully focused on the same things that we're focused on, but had some bad PR. And so that started a whole wave of primary care doctors, primarily internists, trying to get state legislative action against board certification being usable by hospitals or insurers for credentials or empanelment. So I think that that's really dangerous. I understand why people might not want it to be the only thing, and I don't think it should be the only thing. The boards have never said it should be the only thing. I don't think when you apply for privileges that your board certification should be the only thing that people look at. But I do think that hospitals should be allowed to make their own choices about the tools that they use to select physicians. And it's my job to make sure that board certification is such a good tool that they want to use it. So to have politicians, state legislatures, and disenfranchised angry doctors in other fields trying to close that door of professional self-regulation, I think is really wrong. So I think that that's actually what you were asking. Is that right? About state legislative action started by the ABIM that we're all reacting to? Yes. And I'm happy to talk about that more.
Joe, there's a lot of talk both in this country as well as overseas about competency-based training and not time-based training. But how can you even logistically implement something like that?
So we are unique in this dense link we have between education and service. And so it would be easy to do if it was just about education, right? You can do that in almost any field. Medical schools, to some extent, are already taking advantage of that. But the link between education and service is what has made that so difficult. And even in Canada, even with the fabulously successful orthopedic training programs in Toronto, they backed off of shortening the time frame for training. They did give them independence while still in training, but they didn't let them out of the training process early because of that link. So I can't wrap my mind, honestly, around because of the need to have residents do work and the way that our system is currently set up. I'm not sure how much. We may be able to change it by months here or there. It'd be easy to lengthen it, but even lengthening it actually has financial complications related to it. So I'm not sure where we're going to get with that.
But giving credit during your chief year towards fellowship may be
yes.
a version of that.
I think for non-ACGME accredited fellowships, that is quite doable and will be basically in the lap of those fellowships, which we do work closely with to figure out. For the ACGME accredited ones, that requires regulatory change. But everything's a long game, right? If the non-ACGME accredited fellowships can do it, there starts to be pressure on the other ones to make it work. And I do think that we'll end up working down that path.